Hi, my topic is premature rupture of the membrane, also known as PROM. I will briefly be discussing the main points about this topic. To begin, the definition of PROM is a condition that can occur in pregnancy and is described as any rupture of fetal membranes prior to the onset of uterine contractions. We cannot identify one single cause of PROM, but rather a multitude of risk factors. These include previous history of PROM, smoking, history of sexually transmitted infections, low socioeconomic status, vaginal bleeding, and uterine distension, for example, multifetal gestation and polyhydramnios. Placental infection and inflammation and procedures such as cerclage and amniocentesis can also trigger the membranes to rupture as well. Also, PROM is more common among African American females than Caucasian females. What is the difference between PROM and PPROM? PROM refers to rupture at or after 37 weeks of gestation, which makes up about 8% of all pregnancies, whereas PPROM, also known as preterm PROM, is rupture that takes place before 37 weeks of gestation, making up approximately 3% of pregnancies. When you suspect PROM, it is critical to obtain an accurate and thorough history from the patient. These patients will typically report an unexpected large gush of clear, watery fluid from the vagina. On the other hand, some patients will report a dampness on their underwear due to a continuous seep of watery fluid from the vagina. Vaginal bleeding, abdominal or back pain, and fever can accompany these symptoms as well. During the physical exam of a patient with suspected PROM, it is important to maintain a sterile environment to reduce any risk of infection to the fetus. So, digital cervical examination is only used if a woman seems to be in active labor or impending delivery. In all other cases, sterile speculum inspection is preferred and allows the examiner to directly visualize amniotic fluid pooling at the posterior vaginal vault. In some cases, gross pooling may not be visualized, but leakage of fluid can occur when a patient coughs, strains, or has pressure applied to their uterus. It is also important to obtain cervical cultures for bacterial infections such as gonorrhea and chlamydia, as these infections can significantly increase a female's risk of PROM. How to determine if PROM has occurred? In order to diagnose PROM, two laboratory tests are commonly used to determine if membrane has ruptured and amniotic fluid is actually present. One is known as the nitrazine paper test, which is used to determine the pH of fluid present. The average pH of the vagina ranges from 4.5 to 6.0, whereas amniotic fluid is more basic with a pH of 7.1 to 7.3. So, the nitrazine paper will change to blue if the pH exceeds 6.0, indicating the presence of amniotic fluid. However, false positives can occur if bacterial vaginosis, semen, or some alkaline disinfectants are present. Another test used to determine if membrane has ruptured and amniotic fluid is in fact present is the Ferning test. A specimen is swabbed from the posterior vaginal fornix and then smeared on a glass slide. Once it is allowed to dry, it is viewed under the microscope to look for the presence of fine branching structures known as Ferning, which indicates amniotic fluid and confirms membrane rupture. In addition to these laboratory tests, ultrasonography can be used to determine the amount of amniotic fluid present, or it is used to assist with inserting an indigo dye into the uterus. If the blue-colored fluid passes into the vagina and then stains a tampon or a pad, PROM is then confirmed. On to the treatment of PROM. For many years, there has been a constant debate of whether or not to induce labor or manage the pregnancy expectantly after the membrane ruptures. Studies have shown that women who undergo observation and expectant management are more prone to infection. So, if PROM occurs at or any time after 37 weeks gestation, induction of labor with oxytocin or prostaglandin is preferred. If membrane ruptures before 34 weeks, pharmacologic agents are used such as antibiotics to extend the latency period, additional antibiotics to cover group B streptococci if indicated, and a single course of corticosteroids to decrease respiratory distress syndrome and neonatal mortality. There is no way we can prevent PROM from occurring in women during their first pregnancies. However, in those with a history of PROM, progesterone therapy can be used to lessen the risk of subsequent preterm birth. Also, these women can undergo serial sonographic measurements to assess cervical length and possible placement of cerclage to reduce the risk of recurrent preterm membrane rupture. This was a discussion on PROM, and I hope you enjoyed. Thank you.